Thanks so much. It's great to be here. I look forward to this every summer. I've just gotten so many great questions over the years. Now, when we started doing this, if I recall, it was during the pandemic.
Yep.
And there were a lot of questions about staying safe during the pandemic, what was actually going on during the pandemic. But, now we can talk about anything. We can talk about the pandemic. We can talk about whatever is on your mind with respect to public health. So I'm really happy to be here. And why don't we get started? What I've certainly found during the pandemic and otherwise is that whatever's on your mind is the best thing to talk about. And hopefully we can get through a lot of different topics that are of interest.
Sure. So today's session will be a full Q&A. So students, if you have any questions about anything public health, global health, medical related, feel free to raise your hand using the Zoom function, and then we'll get to you. But to start off, Dr. Sharfstein, would you mind telling the students a bit about your journey to where you are now in your career? I know you've had an incredible career,
Sure.
and our students are interested in knowing more about what people's careers have looked like in the fields of medicine, public health, and global health.
Sure, I'm happy to. So I grew up in Maryland, where I now live still. And I went to a college at Harvard, and I then spent a year in Central America after college, where I worked on global health projects, and I learned Spanish. And I came back to medical school at Harvard, and then went and did pediatrics training. So I'm a pediatrician. I trained in pediatrics at Boston Children's Hospital and Boston Medical Center. And I loved pediatrics. What I like about pediatrics the most actually is the relationship you can have with parents. I mean, I love kids, and kids are absolutely great to take care of, but I particularly love the relationship with parents that you get to develop over time as kids grow so much while you're taking care of them. Anyway, I did a special fellowship in pediatrics, and some fellowships are like clinical, like you become a pediatric kidney specialist or a pediatric heart specialist. But I did a teaching fellowship, which, in other words, I can teach pediatrics a little bit better, but it also gave me time to work on policy and public health issues. And I volunteered my time through the fellowship at the Massachusetts Department of Public Health, where I worked on different kinds of projects. At the time, I worked on anti-smoking projects. I worked on newborn screening. You may know that when babies are born, a little bit of blood is taken in a dried blood spot, and it's checked to see whether there's some inborn error of metabolism, some genetic problem that might come up and can be avoided. And so you're trying to identify kids who, if you change their diet or give them some medicines, they won't have a catastrophic outcome. And it's a really successful kind of program. And Massachusetts was really expanding their program. So I worked on that. After that, I came down to Washington, D.C. So I moved from Boston to Washington, D.C. And like you heard, I worked for a member of the U.S. Congress from California named Henry Waxman. Jon Stewart, if you all maybe remember Jon Stewart, he was on The Daily Show. He called Henry Waxman the mustache of justice. So he'd been in Congress for 40 years. He passed all kinds of legislation. He was a very effective legislator. Early in his career, he was one of the people who helped call attention to AIDS and to HIV. He was responsible for the Ryan White Care Act, which provides an awful lot of care in the United States for people with HIV. And he's also worked on environmental laws, insurance expansion laws, vaccine-related laws that have really transformed health in the United States. And one of the best things ever said about him was by someone who opposed him on a lot, who said, and this was intended as a criticism, that Henry Waxman created half of the welfare state while nobody was watching, because he was passing so many laws that expanded access to health coverage and other things. But we sort of took that as a point of pride. So I worked for him for 5 years. At the time, I was seeing patients still on nights and weekends at the emergency department at Children's Hospital in DC. And then but I was living in Baltimore, a city that's about an hour north of Washington, DC. And I took the train down to Washington to work for a member of Congress, and I became next, I applied for and became the health commissioner of Baltimore City. So the health commissioner is the head of the public health department, kind of like you're the doctor for the whole city. All kinds of things are under your purview, from people dying of overdose to people being shot in homicides to the food situation, so many different things. It was a really great job. I worked for 2 different mayors. And then I got involved in a presidential campaign. They needed somebody to represent one of the candidates in Baltimore, and I had a friend on the campaign. And so I was a surrogate, meaning I was debating on behalf of Barack Obama against John McCain at a big medical conference in Baltimore. I don't know if any of you do debate in school, but I was a debater in high school. And I'd sort of left that part of me behind to go into medicine and all that, but I regained it in a weekend and practiced. And I did the debate well enough that I got to be on, do other debates. And then I was part of President Obama's transition into the administration. And I eventually was appointed by the president. This picture I have somewhere. I thought I did somewhere. Oh yeah, hold on. Let me get it. I'll just show you. There we are. I was appointed to the Food and Drug Administration, which oversees a lot of products: food, drugs, devices, food, tobacco. And I did that for a couple of years, and then I became the health secretary for the state of Maryland. So I worked at the local level as a health commissioner, at the national level at the Food and Drug Administration, at the state level as the health secretary for the state of Maryland. And I did that for 4 years. Talk a lot about what goes on at the state level. I've done a little bit of international work since I come to Johns Hopkins. I've been here since 2015, and I teach students, and I write books, and I do different kinds of projects here. I have a class now on the Introduction to Public Health Policy, where we talk about all kinds of public health policies. I have 300 graduate students in the course. But one thing that I notice every year that I do this session is that you guys ask better questions than they do. So I'm looking forward to the Q&A, and feel free to ask me about anything, any health topic or career topic or whatever is on your mind.
Thanks, Dr. Sharfstein. So I think we'll go to our first question from Vinay in Utah.
Hi. First off, thank you for coming. I'm very pleased to meet you today. So my question revolves around Indian health. So the I'm curious to know what reforms you think need to be made to the IHS in particular.
Sure. Well, one of the things that is readily apparent when you look at health statistics is that Indigenous health in the United States lags behind other groups. In fact, it's the lowest life expectancy. They have the highest rates of death from many preventable causes. But at the same time, you notice that there's some incredible success stories, some incredible work that's being done, often utilizing cultural practices and regaining them. The origins of their poor health have a lot to do with a lot of discrimination that had taken place over the years, and the fact that people really weren't paying attention. We have a Center for American Indian Health. Actually, it's now called the Center for Indigenous Health at Johns Hopkins. It's one of the biggest such centers in the world. And one of the key points they make is a lot of times Indigenous people were absent in the data getting collected, and you didn't even see the problems. And now that we are starting to collect data, you see just the enormous gaps that exist. It's years of life expectancy. And so we really need to be thinking both about healthcare, how we have good access to healthcare, which the Indian Health Service plays a really important part of, but also prevention and public health services that help keep a population healthy. Healthcare, it turns out, is only about 10% to 15% of health. When you need it, you need it. But you can have the world's greatest healthcare in an area, but if there's not good food, if there's discrimination, if people can't get good jobs, if they don't, have safe housing, then their health status is going to be terrible, and the hospital is just going to be taking care of all the complications. So if you think about the overall public health challenge of improving the health of Indigenous communities, the Indian Health Service is a piece of that. I think one of the major advances recently is that the Indian Health Service has given control back to tribes in different areas to run the Indian Health Service systems. The system needs a lot more resources. I work particularly on an issue called hepatitis C, where there's a lot of hepatitis C that people with hepatitis C who do not get an effective treatment that could cure them. Hepatitis C is a horrible disease, causes liver cancer and cirrhosis, and there's a treatment, but a lot of people in the Indian Health Service areas cannot get it. And that's because of inadequate funding. So I think that it's a question of governance and funding, but I wouldn't miss the importance of investing in communities themselves for health initiatives. And it's something that we've had the chance to do at the school. We partner with the Center for Indigenous Health. And one of the projects that we're just funding now is to take a model that was developed by tribes to prevent suicide and been proven to be successful, and help to expand it to a whole bunch more tribal areas.
Great, thank you, Vinay and Dr. Sharfstein. Next, we have Pranavi.
Hi, I just want to thank you so much for coming and doing this presentation and like Q&A for us. So I have a question about, this is kind of like a basic question, but like in public health and global health, we hear like about like equity and like health equity a lot. So what exactly is the difference between like equity and equality and like health?
Sure, that's a great question. And I think that sometimes the definitions that people use change over time. So it's always good to ask whenever terms come up, well, what do you mean by that? Just so that we're all on the same page. It's a completely fair question. I think that equity is largely, I think of health equity as people having the opportunity to live their healthiest life without regard for discrimination of all kinds. That discrimination doesn't exist, so that people can do that. And that requires a lot. It requires access to healthcare, but like I said, healthcare is just a piece of health equity. It's just a piece of health. It's just a piece of health equity. Probably 80% of it is outside of healthcare itself. Sometimes when people say equality, they kind of mean equity. So it sort of depends, but sometimes you can distinguish between the two. And a common way to distinguish between them would be to say that equity is that people really are given the ability to reach their highest attainable standard of health based on where they are. And equality is that everybody gets the same thing. So some people sort of draw that distinction. So if you were to say equality might be, everyone has to, gets a certain type of health benefit. But equity would be that people get the health benefits they need to get to their highest attainable standard of health. I don't know if you all have seen the graphic of the kids watching the baseball game, but equality is the graphic of people all getting one box to stand on, no matter how high you are. And some kids can't see the game. And equity is people getting enough boxes so that everyone can see the game. That's another way to think about it.
Great, thank you. Next, we'll go to Sanja from Minnesota.
Okay, thank you so much for speaking with us and sharing your expertise. So with your training in pediatrics and work in the FDA, have you worked with issues relating to childhood nutrition? And if so, what has kind of been your experience with that?
Childhood nutrition?
Yes.
Yeah, well, I've had a few different experiences with childhood nutrition. There was a clinic at Boston Medical Center where I trained called the GROW Clinic. And it was for kids with a condition called failure to thrive, which is basically they're too skinny. And sometimes the problem there is biologic. It could actually fully biologic, like there's an actual malabsorptive condition, something like that. And sometimes and often it's because of inadequate food, and the inadequate ability to spend the time to feed kids in the way that they need to be fed. And sometimes it's a combination of those two things. And this is a clinic that really specialized in that. And they gave out a lot of food, a lot of extra nutritional products. They had a lot of love for both the parents and the kids. The director of that clinic, Debbie Frank, was a real role model for me and just an incredibly inspiring doctor, really helping a lot of malnourished kids. She did one of the first studies that was called the Heat or Eat study. And the reason it was called Heat or Eat is that she looked at the patterns of malnutrition among kids over the course of the year, and she found that the kids were more likely to be malnourished in the winter. And that's because families didn't have enough money for heat and for food. She famously, wrote a big paper about this during the Reagan administration. That was a long time ago. And Ronald Reagan was asked about it. He was asked, is it true that there are kids who are malnourished in the United States, according to this research? And he said he hadn't seen it or something like that, but it made her famous for a few days. So, I think of food insecurity and hunger as being an enormous problem, and a problem that doesn't just affect little kids either. There are a lot of adolescents, and when adolescents don't have enough to eat, they get grumpy. When they get grumpy, they may act out, they may get in trouble in school, they may get trouble at home. And giving kids food is one of the best things to do. And we've done some work here at the school studying different ways to give kids more food, and particularly adolescents. And one of those ways is for kids themselves to get SNAP cards so that they can access food directly, which is a strategy that was tried during the pandemic. So I think it's a really important issue. There are other dimensions to nutrition. We could talk about obesity and other things, but maybe we'll just stop there. I do think it's really important, and having access to healthy, nutritious food is an absolute condition for health and health equity.
Thank you.
Okay, thank you. Next, we have Alana or Elena from Rhode Island.
Hello, Dr. Sharfstein. Thank you so much for being here today. My question is kind of more focused on your career path, because one day I also want to bridge the gap between like just pediatrics and global health and public health in general.
Mhm.
So I was just wondering what opportunities you were able to take control of during this time to get to where you are today, and also what other aspects of pediatrics is specifically related to public health, such as the nutrition crisis or other related aspects.
Sure. So I'll answer those in reverse order. Pediatrics has a lot to do with public health because pediatrics is a lot about prevention. When you take care of really sick kids, it absolutely is just awful. I saw kids, get very sick and die of preventable causes. And it's just, one of the most heartbreaking things you could ever see. And everybody's so upset, and the kids, sometimes they don't even understand what's happening to them. It's just awful. And so you just want to prevent it, You don't want to figure out like the best way to treat kids who swallow board game pieces. You want to figure out how the kids never swallow board game pieces, or the pieces are too big so they can't be swallowed, or you want to fix it somehow else. You don't want to, just focus on the treatment part. And so that creates a natural alignment with public health in many different areas. And I don't just work on kids when I'm in the role like health commissioner or health secretary, but I have a special place in my heart for anything that's going to prevent a problem for kids. And there are a lot of different projects to work on. I'll just tell you one other from the Food and Drug Administration. Well, actually, this was a little bit before I got to the Food and Drug Administration. We found in Baltimore City that there were kids who were dying from accidental overdoses of over-the-counter cough and cold medicine. I don't know when you were sick, whether you ever got cough and cold medicine from your parents. That has never been proven to work for kids. And yet kids can overdose on them, particularly when the grandparent gives a dose and the mom and dad gives a dose, and then suddenly there are too many doses. And we had 4 kids die inadvertently of this in Baltimore City. And there was no evidence on a single study for kids under 6 that the cough and cold medicines, I don't want to overbroaden it, but there's no evidence that they worked. So we did a petition to the federal government, and the companies were forced to withdraw all those drugs from all over the country for kids under 4. And so I have in my office here a one of the boxes you will not be able to find. It's called PediaCare and has a little dropper in it and a little baby on the front. But I bought this before they came off the shelves, just so I could have a token of reminding myself about it. But this is about prevention. You know, we don't want kids who are going to take a drug that doesn't work and wind up, you know, unfortunately harmed by it. And I got to work on other types of issues. I don't know if you guys ever seen bumper pads that are inside cribs. You know, there's like bumpers around in like a little padding inside the crib. That is not a safe thing. You want babies to sleep alone and on their back in the crib, but not with pillows and blankets, because they can asphyxiate. And so, but every single crib was sold with this huge bumper, and kids were getting strangled or smothered by the bumper. Not a lot of them, but like, you know, how many do you need for it to be a problem? And in fact, those bumpers, they don't actually protect kids because the kids are too small to really hurt themselves by, you know, knocking their head against the side. So they're unnecessary. And so we, when I was working for the state, we banned the sale of them in Maryland. And soon afterwards, they were banned by state of Ohio, the state of New York, and recently Congress banned them. So they're gone for the country. So, you know, the chance to work, you know, get rid of products that are dangerous to kids, that's been a really, you know, worthwhile part of my career. You were asking like what parts of my career, what opportunities I take advantage of. You know, there are sometimes little grants you can apply for in different places. So when I was in college, I saw that there was a grant program that allowed me to travel and work on public health projects. And so I had to find public health projects to work on. And I like wrote everyone I could think of and called and called and called. And I got this really nice woman at this global health organization called Project Hope. And she arranged for me to go to rural Guatemala if I could pay my way. And then when she said, you know, hey, if you can get the money, you can do this, then I used that letter to go get the money to do it. Now, I got a grant for an entire year to travel. It was $8,000, but that was enough to do back when I did it in the early 1990s, you know. And I actually found recently, I think it's at home, not here, my log of every dollar. I was so worried that I would run out of money and have to come home soon. Every dollar. And on that list was call home, because there were no mobile, there were no internet cafes. Most people didn't have telephones where I was. You had to go to a central telephone place, and then they would make a call for you, and they go into room 3, and you pick up the phone, and then you could talk to your parents. And I did that maybe once a month, you know. So compare that to now, where, you know, if my kids aren't texting me every hour, I'm like, what's going on? It's very different.
Thank you. Next we have Jackson from Georgia.
Thank you, Dr. Sharfstein. I was wondering how the pandemic impacted the pediatric care, as well as what is it like now compared to, I guess, 2020, like how has it changed? And
Sure. So, you know, one of the things is I stopped doing a lot of pediatric care. I really don't do pediatric care anymore when I got more and more into my policy jobs. But during the pandemic, I did volunteer to give shots and do other things like that. So what I'll tell you isn't from my direct experience anymore. You know, COVID can cause some pretty severe disease in kids. It can cause it directly, which is where kids get COVID pneumonia or other complications. And it can cause it indirectly when there's like a immune system reaction to COVID that can cause very severe symptoms and even death in kids. And so there have definitely been kids who have died of COVID, and why, you know, we recommend vaccination to significantly reduce the risk that happens. COVID put a lot of kids in the hospital, and that really stressed the hospital system, particularly when other respiratory viruses are there. And, you know, every year there's a flu season, every year there's an RSV season, and, you know, the hospitals fill up. And then you add COVID to that, and particularly if it happens at the same time of year, and you can swamp the number of hospital beds, the number of ventilators, and that was starting to happen a couple winters ago. It was just a terrible winter for kids. Now, one of the interesting things is if you're working in the hospital in the middle of flu season or COVID season or RSV season, you see the same thing present in different ways. And what do I mean by that? Like, sickle cell anemia is a terrible disease. And kids with sickle cell anemia can get crises where their blood sickles and it causes horrible pain, and they come in just the worst pain. It's absolutely horrible to see. But a respiratory infection can cause that. So during flu season, you might see a young person come in with a sickle cell attack. And you go like, why is that happening? Turns out that that's flu. Then there's another child who was born prematurely and maybe has some breathing issues, and they get really sick because of flu, but it looks different. And somebody who is immune suppressed may have disseminated flu, and it looks different. So it's the same pathogen, it's the same virus, but it looks different in different patients. And so, that's a clinical challenge, but it also means that during the time of the year, you've got to be ready for everything that could come in, even if you're really, the underlying cause may be somewhat similar for most patients.
Thank you. Before we go to Suchir, I see a question in the chat that has quite a few thumbs up. It's from Braden. And Braden, just in case we need any clarification, I'll just be prepared to unmute just in case. But he says, thank you for speaking today. I'm from Canada, and one of the big issues where I live is a shortage of family doctors. We have universal healthcare here, which is supposed to make good healthcare available to everyone. Unfortunately, there are millions of Canadians in Ontario alone who don't have a doctor. How can a high school student be a part of the solutions to this problem? There are very few med school spots available, and it is extremely competitive and expensive. Without primary care doctors, everyone suffers.
So it's a great question. I completely agree. The primary care is really the basis of every successful health system. Somebody who can really help an individual stay healthy, but also be there to support diagnosis and treatment and navigation of whatever health issues come up. And people who don't have primary care doctors can bounce between specialists and sometimes get conflicting advice and not really have the best treatment plan for even serious conditions. So I totally agree with the premise. The gaps in primary care are significant. They're enormous in the United States. They apparently also exist in Canada, which I can believe. Let's talk about why they exist. Why are there fewer people doing that kind of primary care job? And also what can be done about it? So oftentimes the reason is that there are not enough doctors overall. That's one possibility. Another possibility is that the money and financial incentives bring people to become specialists. And in fact, primary care doctors get paid a lot less than specialists like radiologists or dermatologists. And the third area is sort of prestige and how people, are able to organize their lives. Like some physicians are able to have regular hours and they get paid a lot, and that's just what they want to do. And they're able to do it. But primary care doctors often have to be working long hours. And then a fourth factor is that there can be a lot of paperwork and expectations on primary care, and some people get really frustrated by that. So the solutions are to kind of undo each of those things. Some areas you really do need more medical school spots, and maybe more loan repayment or other support for people to go into primary care jobs. The insurers, which could be the National Health Insurance System in Canada or in the United States, private insurers or Medicare, really do need to pay more for primary care. And there are all kinds of reasons why that hasn't happened, but fixing that is really important. You need to make it easier for primary care doctors to do their jobs. One model that works, if it's done well, is called a medical home model, where there's extra payments to the primary care doctor's office so that they can take better care of their sickest patients. So that's important. And in general, we need to, really respect primary care. I'll tell you, my mom has had a medical issue in the last few weeks that she's got very worried about, that she's calling me a lot. I said to her that I wanted to talk to her doctor about it. And my mom was like, I don't want you to bother that poor woman. And I said, no, I really, I want to help you, but I need to understand what your doctor is thinking. And so my mom wrote her permission and I talked to her doctor. What an amazing person. First thing she said to me, I'm worried about my mom, of course, but I'm also a little worried my mom is so anxious that she's making taking up a lot of time with the doctor. The first thing that this doctor said to me was, Josh, I want you to know that your parents are not bothering me. I love them. They're absolutely the sweetest people I've ever met. Now, I don't know if that's fully true, but boy, was that a nice thing to say. My parents are pretty sweet, but I don't know whether they're the sweetest people she's ever met. But then she proceeded to tell me exactly what she was doing, what she thought was the right thing to do, how she was, calling different specialists to help. It's unbelievable. And I just thanked her a million ways. And I called my parents and I said, I hope you realize you have just a phenomenal primary care doctor and you should be very, very nice to her. So I think it'll work out for my mom, but it was a really, really hit home, the question that Braden's asking here.
Great, thank you. Next, we'll go to Suchir from Missouri.
Hi, Dr. Sharfstein. Thank you so much for taking the time to present today. I was wondering, the FDA plays a crucial role in ensuring drug safety. So can you share an example of a challenging regulatory decision related to drug approval or post-marketing surveillance that you were involved in, and how the agency approached balancing public health interests with patient access?
That is a great question. Can I ask what led you to ask that question?
So I was just wondering, since there's a lot of issues related with the FDA and approving drugs, and there's a lot going around with the system that the FDA uses to approve these drugs. So I was just wondering what that system looks like and what the challenges were.
It's a great question, and it's very important. The FDA has a really important responsibility because the FDA is sort of the last line of defense before something gets marketed to millions of people that can improve their health. And so you want to find the products that are really going to help, and you want to keep away the products where the harms outweigh the benefits. And so there's a lot of evidence and studies and research that goes into putting any drug forward, a prescription drug, so that you can judge as well as possible, whether something works. But there's some complicated situations because you have to balance sometimes the benefits against the risks. I'll tell you, you asked me for one specific example. There was a medication called rosiglitazone, otherwise known as Avandia, which is for people with diabetes. And it lowered the blood sugar, so that was good. But there was a concern that was raised that it might cause heart attacks. So on the one hand, lowers the blood sugar, on the other hand, causes heart attacks. And there were a number of people who were saying, you absolutely have to take it off the market. And some people were saying that, and other people were saying, actually, we don't know for sure it causes heart attacks. We know for sure that it reduces blood sugar and helps with diabetes. So maybe we should just wait, pretend that it doesn't cause heart attacks until we know 100% for sure. So it was actually a pretty contested policy issue. There were newspaper articles about it. There was all kinds of different debates about it. And we decided, we wanted to get some expert input. So we convened a panel of experts from around the country to look at the evidence and tell us what they recommended that we do. And the panel split. Some people said, leave it on the market with no restrictions. Some people said, take it off the market, the harms outweigh the benefits. And in the end, we did two things. First of all, we kind of advised against it, but we left it on the market for people who really felt like they were getting a lot of benefit and their doctors wanted to keep it. So it was going to be a much smaller group. But second, we explained our decision in an article in the New England Journal of Medicine. Someone could probably find the reference and stick it in the chat if you're interested. It was called Regulatory Action on Rosiglitazone was the name of the article, and it's been cited a lot. But we tried to walk through our reasoning. So these are difficult cases, and I think it's important not just for the FDA to make a decision, but to explain the decision. If you have a lot of power, you can just say, well, I got the power to do this. Boom, this is what I'm doing. But then people will gradually hate you for it. That's my experience. They'll go like, wait, why did you decide that? Didn't you take into account this? Or they'll even do worse. They'll say, I know why he decided that. He decided that because, and it could be completely untrue, but they're going to come up with those stories unless you tell them why you did it. And so one of the main things that I've worked on in my career related to FDA is transparency and saying it's critical when you make a decision to explain why and be willing to revisit that decision if the evidence changes. It's not a permanent decision. So there are a lot of issues. Another big one for the FDA, I'll just mention briefly, has to do with opioids, because opioids can really help with pain, but then you can get addicted to them. And of course, a lot of people got addicted to opioids. And the FDA was definitely, part of the problem for a long time, in part because the FDA allowed the companies to make claims about opioid medicines, including that they were unlikely to cause addiction. So that might have led a lot more people to prescribe it. The FDA has now kind of shifted its posture and has a special toolkit. It's called REMS, where the FDA can put special restrictions on medicines to try to make sure that the benefit risk kind of trade-off is positive. And so that might look like only certain patients can get a very powerful medicine, or that in some cases, only certain pharmacies can distribute those medicines. It sort of depends on the particular medicine and what to do, or that doctors have to take training courses. So there are all kinds of tools to try to do this. I support the use of those tools, but more than anything, I think it's really important for the FDA to explain its thinking so that people really understand and that those decisions can be revisited as necessary.
Thank you. Next, we have Rebecca from Indiana.
Yes. Hi, Dr. Sharfstein. First, I wanted to thank you so much for taking time out of your day for this Q&A. I really appreciate it. I kind of wanted to ask like a general question about your career as like a pediatrician and like as a doctor in general. I was wondering what inspired you to go into public health and like medicine, if you have like a specific instance that inspired you to go into that. And what part of your career as a physician makes you love even more what you do every day?
Sure. So I'll be, honest, I was not a science major in college. So a lot of people go into medicine or science major in college. I was a political science major. It was called social studies major. And I took pre-meds in college because I wanted to have the option to go to medical school, but I wasn't sure. It also helped that it got my parents off my back.
Yeah.
Both of my parents are doctors. I'm the oldest grandchild, the oldest child. And so I had a lot of expectations on me for going to medical school. And in fact, when I was 5, I was asked what I wanted to be when I grew up. And I said, do I have a choice? But seriously, I didn't. I just thought I was assumed that I would be a doctor. Now, I know a lot of people don't have that experience. It's not that their parents are doctors, but they feel driven in a different way. I was never quite driven. I just knew that it was a possibility because my parents put it on the table for me. And I had a choice of what to do for summer jobs in college. And I actually chose to do summer jobs working on political campaigns. So I worked on a bunch of different political campaigns in college, and I worked my way up to being a speechwriter, which I thought was which was actually my original career aspiration, was to be a speechwriter. And I got to write speeches. And at the same time, that same summer, on the nights and weekends, I was a volunteer at DC General Hospital, which is a public hospital that's now closed in Washington. And during the day, I was writing these speeches, and I was finding it very frustrating because I remember we were talking to a member of Congress who we were working for, and he was upset that his opponent was calling him a liar. And the consultant that I work for said, well, let me tell you something. He's calling you a liar once, but we have 3 times as much money as him, so we're going to call him a liar 3 times. And I was like, God, what are we doing here? And then on the weekends, and it was a great job for a college student, you know, I was like on my way in political consulting, but I was really looking forward to the weekend. And on the weekends, I would go with a guy who his previous job was a supermarket shelf stocker. He would put stuff back on, and he was hired by the hospital as an assistant to the nurse's aide. So he was the lowest person, you know, in the hierarchy of the hospital. And I would follow him around the whole time for 12 hours. And we would see people who were shot, people who were heart attacks, people, whatever. And he just talked to me. And what became clear is he had an incredible sense of purpose doing the work and ethics. He was very sweet to the patients. We took care of patients who had just profound disabilities, and he was so courteous to them. And I just loved watching him take, you know, even though he was not a physician, and I, of course, would love to know where he is now. But it was inspiring, and I just got so much out of it. In the end, I went back to college and decided to apply to medical school. My parents were very excited. They weren't as excited when I told them I was going to take a year off between college and medical school. In fact, my dad famously told me, you know, I have a friend whose son said he would do that, and my friend went to see his son and broke his arm, and then he went right to medical school. And I said, Dad, was that a threat? Threatening to break my arm? My dad's like a pacifist who like protested the Vietnam War. I was like, are you threatening to break my arm? And my dad said, no. And I said, because I really want to take a year off, and you can decide, either you'll let me take a year off or I won't go to medical school. And there was this long pause on the phone, and my dad said, I think year off would be great. You know, you'll have like a chance to explore different things, and you'll come back refreshed for medical school. So it all worked out.
Thank you so much. I appreciate it.
Sure.
Thanks. Next, we have Nurul Ain from Florida.
Yes, thank you so much for your time today. My question was, what career paths would you say are optimal for someone who's interested in working in public health and health policy? And what advice would you give to someone who's looking into that kind of career path?
Well, first, I would say it's an amazing career path. You know, public health gives you the satisfaction. You could walk around an area and say, I'm making this whole place healthier. Like I worked on this project to improve infant mortality in Baltimore. We developed this huge coalition, hundreds of organizations and people working together to, you know, keep kids sleeping safely, less tobacco, investing in communities, all these different things. And we had the lowest infant mortality rate and the biggest drop in disparities in infant mortality. And now people don't know your name for that, you know. It's not like you're the surgeon who cracked their chest and, you know, pumped their heart with your bare hands, you know. So it's different, but it's an incredible satisfaction in my mind, in my experience, to walk around and say there are kids. They may not know it's them, but there are hundreds of kids who are alive because of the efforts that we put in, you know. And so I think it's a great area, and you know, there are a lot of different ways to get there, you know. And so I think what you want to do, there's not one career path that is the best. You know, my wife and I have different approaches. My wife is actually quite a career of her own. She's an addiction medicine doctor, but she runs a major part of the federal government called the Center for Addiction Treatment Center for Substance Abuse Treatment at the Substance Abuse Mental Health Services Administration and HHS. So she runs an office with a budget of a few $1 billion a year and a lot of regulatory authorities. She works all the time. She and I have had different approaches to our careers. We met on day one of medical school, by the way. There was like a square dance, and they randomly assigned partners, and she was assigned to me. And we both realized we'd taken a year off before we went to medical school, and we resolved that we would have lunch to talk about our years off. And here we are 25 years later, actually 30 years later. So, but our approaches to our careers have been very different. We've both been supportive of each other, but we've been on our own path. When I take a job, I just throw myself into it, and I don't really think about what's coming next. I'm not like strategic one job to the next. I remember when we had 2 little kids, and my wife said to me, this weekend, I've got to go into work. I've got to catch up on work. I've got to catch up on work. I was like, fine, fine, fine. I'll take them. What I used to do is I would stick 2 diapers in my pocket and, drive to Sesame World or something and see whether we could survive for how long before we had to go racing back. But in the meantime, my wife was working. So she works the whole weekend and she comes and they go, well, did you get, and she showed me this huge to-do list, to make the case that she needed to go into work. And I was like, well, how many things did you get done off your to-do list? And she's smiling. She goes, I didn't do any of them. I said, well, why are you smiling? She said, well, it's because I made a 1-year plan, a 5-year plan, and a 10-year plan for myself. So she is very strategic. Like, this is what I want to do, and this is going to lead to this. And I've never been like that. I'm like, okay, I'm health commissioner in Baltimore. I'm going to work on that. And then somebody showed up and said, do you want to be a debater for the president? So I think, it partly depends on your personality. If you're somebody who really wants to think about 3 steps ahead, you can think about 3 steps ahead, but you don't have to. I think if you do the job that you're in as well as you can and keep your eyes open and learn, then one thing can lead to another. And it's great in that regard. If you want to be like a certain kind of doctor, you have to follow a certain path. If you want to be like an expert in the left anterior descending artery, the electrophysiology of that, you're going to go to medical school, you're going to do cardiology, you're going to do an EP fellowship, and then you can do a sub-fellowship. You have to. But in health policy and public health, there are a lot of different paths. And you want to do things that make you happy. You want to be places that you want to be, surrounded by people that you care about. And then you kind of see what happens.
Okay, thank you. Next, we have Nicole from the UK.
Yeah, thank you so much for coming and answering all of our questions today. So I'm kind of interested in going down the same studies and career path as you, merging medicine and politics. So I'm really interested in hearing more about your job as the former secretary of the Maryland Department of Health and Mental Hygiene. And yeah, just if you could elaborate on what it was like having a job merging medicine and politics.
Sure. Well, I'll give you a specific example from that job. Maryland's a little bit unique. In that we pay for hospitals differently than any other state in the country. Every other state in the country, the insurance companies negotiate the rates with the hospitals, and when patients get sick, they go to the hospital, and the hospital gets paid. Fundamentally, it's not that different from paying for hotels. If you're in California, you go to the hospital, and your insurance company or you pays for that time in the hospital. So it's like you go to a hotel and you get a bill. But in Maryland, it's not like that. Maryland, first of all, for many years, since I was a kid, has had a system where there's a commission that sets the rates that the hospitals are allowed to charge. And then when I became health secretary, that system started to get a little weak, and we changed it to fundamentally alter hospital payment, where we give a budget to each hospital. So no matter how many people come in, the hospital has the same budget. This is a slight simplification, but that's the concept. So suddenly, the hospital doesn't just get paid when people come in. The hospital's got to think about how to keep people out, how to keep people healthy, in other words. And so we have very expensive, healthcare system in the United States and very poor outcomes. And one of the reasons I think that's the case is we pay people a lot when people are really sick. So we have a lot of sick people, but you can just pour money into the care of stroke patients, but it's a lot cheaper to prevent strokes. But if you're only paying for people when they have strokes, then you're going to not get the investments you need in prevention. So as health secretary of Maryland, I was very involved in transforming a system to make it more about the health and prevention and global budgets. To do that, I had to talk to the politics part. I had to explain it to all the legislators, to the governor. I had to explain it to the hospitals themselves. I had to go back and forth with the hospitals. Now, I didn't do it all by myself. I had a great team. I had a partner who worked at the Payment Commission. We went all around the state to make the case. And eventually we were able to do that. And Maryland has saved a lot of money, and there's been a lot of health improvements since then. But it was an example of something that really brought together the health and the politics.
Thank you. Next, we have Maba from California.
I just wanted to start and say thank you for taking the time to present and answer our questions today. Recently, I've traveled through Europe. This summer, I noticed some differences in the foods that were sold in the market compared to America. They seem healthier, and my cousins told me that they were in fact healthier. Do you think this is because food regulations in Europe is much better or stricter? If so, why hasn't the FDA put stricter regulations on foods that are known to lead to numbers of diseases?
Are there particular foods you're thinking about there?
Basically, what I noticed was when I went to the chips section, there's no hot Cheetos, and I've heard that hot Cheetos do have red 40 dye in them, and the crisps or the chips are very much bland, if I were to say, like they don't have a lot of the candies that we have in America. It's very much like different, if I were to say. And people there say there's less sugar, there's less salt. That's like only the amount of ingredients that are needed are in it. There's not too much sugar in their cereals. They basically don't put too much of anything, is what I've heard when I was in Europe.
Interesting. I mean, I don't know enough about European food regulation probably to give your question a fully baked answer. But I would say that regulations do vary from country to country. And you have to distinguish between what's actually in the products and what the packaging says, a little bit. So sometimes countries will allow people to say things are healthy, but they're not actually healthier. So you'd really have to look. And I think if you were going to look, you could look at food additives and the differences in the food additive laws. And you could look at things like sugar and salt content. I do know that Europe is definitely ahead of the United States in salt, or parts of Europe are. Salt contributes to hypertension and leads to strokes, and you can really improve entire populations' cardiovascular health by reducing the salt intake. So that one I'm very familiar with, and it's important. Now, diet really matters to people. Like what you eat really matters. If I told you I'm taking away your favorite 3 foods, you wouldn't be like a big victory for public health. You'd be like, this sucks. It'd make you a libertarian right away. It's hard to change people's diets, and particularly when things have been marketed to them, and also that it's something that they loved eating since they were kids. So it's super hard, and most people think in the United States that like a good next step would be very strong labeling, at least, so people could really see what's in there more clearly. The nutrition facts label is good, but it doesn't really tell you red, yellow, green, for example. So more on that might be a step towards healthier foods in this country.
Thank you. Next, we have a group from California.
Hi, Dr. Sharfstein. So since you've been in like big leadership positions surrounding in public health and also policymaking, I was wondering what you have done in regards for tobacco regulations, since many states have also taken action in banning flavored products. But even where I am now in California, I still see like people around me at school holding flavored products, flavored vapes. So I was just wondering what is happening at the federal level to like protect these youth, and what your experience has been in this sector.
Sure. The evidence is pretty strong that just like you say, that flavors are particularly attractive to kids. And I've seen people with a straight face say that, flavors that are like Tutti Frutti and, root beer and all kinds of other things have no interest to kids. And it's like, really? Do you think that's true? But the evidence is very, very strong across a bunch of different products. And when I was the state health secretary in Maryland, we had a big campaign to try to warn about flavored cigars, which we were worried about. When I was at FDA, the tobacco law had just passed. Actually, soon after I started, the tobacco law passed, which gives FDA the authority to move on flavored products. And in fact, it took all flavored cigarettes off the market. FDA is, I believe, I need to quadruple check this, but I'm pretty sure is very concerned about flavored vaping products. And the industry has been sort of dodging FDA regulation in different ways. for a while, they were saying that the tobacco law only covered nicotine derived from tobacco, not nicotine made in the lab, but Congress eventually closed that loophole. So hopefully the FDA will take some action against products that are particularly attractive to kids. Now, vaping products, electronic cigarettes are a bit of a public health conundrum because they can also help people who smoke quit. So this is one where you have benefits and risks. And in this case, the benefits may be accruing to one population, people who smoke, and the risks accruing to young people, who could get addicted and then go on to smoke or just never be able to stop using nicotine, which has its own health harms. So it's a tough dilemma for FDA. And I think that you have to regulate to maximize the benefit and minimize the risk. I think taking flavors off the market is a way to do that. You're not taking all the products off the market, but you're taking off what makes it particularly attractive to young people. But there are other kinds of regulatory strategies that can be used. And one that I've written about is imagine if you took away all the revenue from companies based on their market share for kids. So you did a really good study that said, okay, Josh's brand of vapes, 10% of Josh's brand of vapes is being consumed by kids under 18 or 21 or whatever age you pick, 10%. Then you go, okay, we're going to put a tax on your product next year that's going to reduce your market by 10%. We're going to collect all that money back. And so the companies then, right now, of course, if more kids buy it, well, then maybe they'll be using it. It's an economic benefit to the companies. But could you use tax policies so that actually the companies don't want to get kids to do it because it could cripple their ability to sell more broadly? So that's just a different kind of regulatory idea.
Thank you. And before we go to the next session, I know we have a few minutes left for our scheduled time for today, but Dr. Sharfstein, should we do, I think last year we did rapid fire questions or something to try and get through as many as we can, or did you just want to take a few?
Let's see. What I would say is, why don't we do, let's do 3 super fast questions.
Okay.
And then we're probably going to have to stop.
Sure, sounds good. So we'll go to Eli, Sarah, and Mysoon. We'll first go to Eli from Utah.
Okay, so earlier when we were talking about like the Canadian healthcare system allows a lot of people to not get like primary caregivers. But in America, we kind of have like a classless healthcare system where you only get kind of resources if you have money. So how do we get a more equitable system where we don't have to deal with like just a classless healthcare system or one system where no one gets anything?
Good question, Sarah.
Hi, Dr. Sharfstein. I wanted to ask you if you could talk a little bit more about your work in Central America. My family's actually from El Salvador, and I'm interested in hopefully improving public health in indigenous regions over there. So it's really inspiring to see you doing work over there in such developing countries. So.
Thank you. And Mysoon?
Just wanted to say thank you for coming and taking time out of your day to answer our questions. But I was particularly interested in maternal and child care, and I've noticed that maternal mortality has been a major issue not only in the United States but globally as well. So my question is simply, based on your experiences, what do you believe is like the most significant cause of this, whether it's like healthcare accessibility or social difficulties, and are there any strategies for people to overcome this?
Great. Those are great questions. And let me just say, as predicted, you guys asked phenomenal questions. Really great. Don't lose that willingness to ask questions. Sometimes by the time people get to graduate school, they're afraid of embarrassing themselves with a question. And so their questions they ask are really very, very tiny questions in a way. But you guys ask the big questions, and that's the right way to go. That's really great. So the first question is about how to make our healthcare system more fair and just, which is a really important question. It's very difficult. Don't know that I think it's true that only people with money get healthcare in the United States, but I think that people with money absolutely can get, are much more likely to get the healthcare that they need, and there's tremendous inequity. There are a lot of different potential solutions for that. I think one of the biggest inequities right now is that there are a number of states that haven't expanded Medicaid yet, and Medicaid can provide a lot of important access. So, one of the challenges we have is how much to work for partial solutions when you want to just fix the whole thing. It's been a challenge in my career. How do you decide what to work on and whether you're going to accept things that are partial, recognizing that there's still injustice in that. And you can make a different decision. I mean, everyone can make a different decision on how they want to proceed. I worked for a member of Congress who said our job is to make people's lives better, even if it's incremental. He's the guy who built half the welfare state while nobody was looking. If he waited for it to be the full fix, he would still be waiting. So you have to kind of decide. I do think that fully implementing the Affordable Care Act, strengthening the Affordable Care Act, doing things like what Maryland does for hospital payment can make a lot of progress, but it's probably not going to completely solve the problem that you raised. And we have to have in the back of our mind more fundamental reforms if the opportunity is possible. Central America and a young woman from who has family from El Salvador, it is just a incredibly amazing place. And the work that you can do here and there and in partnership between the two can make just a huge difference. I had an incredible experience working in Guatemala, later in Costa Rica, and I came back, I saw patients in Spanish. It really helped. I'll just say one quick story. When I was a medical student, I didn't know anything. My very first time I was on rounds in a pediatric hospital, we went and the doctors were talking in front of the parents who obviously only spoke Spanish, but they weren't explaining anything to them. And at the very end, while the doctors moved on to the next room, I hung behind and I explained to the mom what was happening. And then we went across the whole ward. And as we came out, there was a group of moms waiting for us to come out of the room. And the lead doctor said, "How can I help you?" And they said, "No, we'd like to talk to that guy." And they pointed to me. I was like the way in the back. And everyone turned around to me and they said to me in Spanish, "We want to hear what's going on with our kids." And so, it was an incredible value to me in the United States. So it was just amazing to work there, incredibly important for the work that we do here. And you're in a position, if you can kind of cross between both worlds, to make all kinds of difference. And I would totally encourage you to do that in different ways. And the last question was maternal and child health, which is enormously important, and amazing progress has been made in maternal child health. And so much more needs to be made at the same time. And I would just suggest that you look at some of the progress that's been made in improving nutrition and vaccinating against preventable diseases and raising the standard of living. We have a lot of work to do. Reproductive health is really important for maternal child health. And obviously there are parts of the United States I think are slipping backwards in that regard. But it is a very, very rewarding field because you see the numbers move and behind each number is somebody. And we're talking about a lot of people. So in public, in surgery, you can point to the people whose lives you saved. In public health, walking around that you've contributed to saving thousands or even more lives yourself. And it's just an amazing feeling. So thanks for the chance to be with you all again. Sorry we didn't get to all the questions, but look forward to other ways to be in touch.
Great. Thank you so much, Dr. Sharfstein, for the excellent session. As always, it was an honor to have you as a part of our program once again.
Sure. And just to tell everybody, we do have a podcast at Johns Hopkins called Public Health on Call. And I do a lot of the interviews, a lot of topics that we've talked about today have come up. So you can check it out wherever you get your podcasts.